Hi, I'm Steve Selig, founder of Fit Test. A few people have asked me to put the main points into a summary presentation for atrial fibrillation and exercise. So in part 6 of this video series on atrial fibrillation, I have done that and really covered the topics around what is atrial fibrillation, the commonly prescribed medications for rate and rhythm control, and also the interventions, including the ablation therapies. So first of all, what is atrial fibrillation? Let's look at the normal heart first. So in the normal heart, the sinoatrial node or sinus node is the main pacemaker tissue. This is the tissue that drives both the rate and the rhythm of the heart. And so it starts in the upper right atrium or the upper right chamber, and then it spreads in a coordinated fashion throughout the upper chambers. And then a split second later, it then gets down into the bottom pumping chambers. And the contraction in the upper chambers is responsible for about 20% of the filling of the lower chambers, which means that the other 80% is just through passive filling of the lower chambers from the great veins, either coming from the venous system or coming from the lungs to fill the left chambers. And on ECG, we see the atrial contraction shown here in the small P waves, and then these larger spikes here that are in rhythm are the ventricular contractions, the contractions of the lower pumping chambers which dominate. And so in a normal sinus rhythm, we have, as the name suggests, we have a consistent rhythm between, or the distance between these ventricular spikes, giving us a rhythmical heart and a rate of about 60 or 70 at rest. In atrial fibrillation, what occurs is that the atria become electrically chaotic, in the sense that there are wavelets of electricity occurring all over the atria, and it essentially electrically knocks out the sinus node, so the sinus node can no longer do its job to control the rate and rhythm of the upper chambers and therefore of the whole heart. And so we have this chaos occurring in the upper chambers, and at random intervals, and you can't see it on this diagram, but there's another pacemaker cluster about here called the atrioventricular node, and this acts as an electrical gateway into the bottom pumping chambers, the ventricles, and it controls what comes through from the atria into the pumping chambers below. Now, when we have this chaos of atrial fibrillation, at random times, so not in rhythm, at random times, the electrical activity hits up against the atrioventricular node and then gets into the ventricles, and we end up with an arrhythmia, or a rhythm out of rhythm in the ventricles, and that's shown very clearly here on the ECG. So the two features of the ECG that you can see in this situation of atrial fibrillation is we have fibrillation along the baseline, which is really reflecting these chaotic wavelets that are occurring in the atria. And we have the ventricles that are out of rhythm here, shown here, because of the random times in which this electrical activity can get into the ventricles. Now, what are the problems then with atrial fibrillation? Well, before I get on to those, just one other brief comment. And that is, I've already said that over here in the normal situation, about 20% of the filling of the ventricles occurs from this coordinated contraction here in the atrium. We lose that in atrial fibrillation, but the person is still very much alive because they still get 80% of the filling coming from the flow through the atria from the great veins into the two pumping chambers, the ventricles. So this is not a deadly rhythm by any means. The person is alive and relatively well, although it's certainly not ideal. But they get about 80%, and they can actually still exercise quite successfully using other means that I'll talk about in other videos in this series. So coming to the problems, because the atria is sitting there almost shimmering like a jellyfish with not coordinated contraction, it means that a blood clot can form. And I've just illustrated here a blood clot forming in the upper left chamber, the left atrium. If that blood clot was to get through the heart and into the blood vessels supplying the brain, this could cause a stroke. And in fact, it's one of the most common reasons, common causes of stroke in Australia in 2020. The heart can also beat too fast, making exercise potentially unsafe. And this is again because we have this chaos occurring here. And if the atrioventricular node, which is not shown here, but acting as a bit of a brake on heart rate, if this lets too many of this electrical activity through, the heart rate will beat very fast. And one of the prime medications that are given to control rate are beta blockers, which work at the atrioventricular node to just slow down the amount of conduction through into the ventricles. So in exercise, people with atrial fibrillations can exercise, but my strong recommendation is those clients need to consult with a clinical exercise professional, such as an exercise physiologist or a physiotherapist. Now, just going on with what a blood clot can do and how we can protect, or how cardiologists and general practitioners protect against this, is one class of drugs given is an oral anticoagulant. And in modern medicine, the classes of drugs that are most commonly given are the XA bands, the XA bands, which is really, it's an easy way to remember it because it blocks factor 10A in the enzymatic cascade for the formation of thrombin, which is a critical step in the blood clotting process. And it blocks factor 10A, so XA band. It's a really easy way to remember it. And then we have the trade names in brackets. Of these XA bands, or the XA bands, the far most commonly prescribed drug is rivaroxaban or Xarelto, and the next would be apixaban or Eliquis. Now, there's another class of drugs here, dabigatran or Pradaxa, which is a direct thrombin inhibitor right at the end of the thrombogenic enzymatic pathway, and that is also quite commonly prescribed. If someone has valvular atrial fibrillation, they normally need to stay on quite an old drug, which was prescribed widely before these oral anticoagulants became commonly prescribed, and warfarin. The problem with warfarin, although it has to be given for valvular AF, and it is a vitamin K antagonist, the problem with it is that it has a relatively narrow therapeutic band, which means too little and the patient will clot, and too much and the patient will bleed. And there's quite a narrow therapeutic range there, and so they have to have their blood levels of warfarin regularly monitored. Now, if someone is in permanent or long-standing atrial fibrillation, the critical thing here is that the heart can beat too fast, making exercise potentially unsafe. And so what you need to be looking for as an exercise professional is an AV nodal inhibitor, which is that other node supplying the ventricles, the bottom pumping chambers. And what you need to be really looking for are beta blockers primarily. And the three main beta blockers which are given to control heart rate in people with permanent or long-standing atrial fibrillation are atenolol, metoprolol, and sotalol. And you'll see sotalol come up another couple of times in this video. So these are the first-line drugs for rate control in atrial fibrillation. And but there are other alternatives that can be given too, and that's the calcium channel blockers, which are basically membrane stabilizers in terms of electrical stabilization. The two main drugs being amiodarone and sotalol. And the third main drug I want to alert you to is digoxin or lanoxin, and this is has one of its actions is it blocks the AV node to slow down the conduction through the AV node. Now, I want to just, I haven't touched yet on the anti-arrhythmic medications. Now, these are given with the aim to actually use these medications to get someone back into or maintain sinus rhythm in people who are susceptible to atrial fibrillation. And the two main drugs here, again, appearing as we had in the previous slide, but for a different purpose, the calcium channel blockers, amiodarone and sotalol. So on the previous slide, I made the point that these can control heart rate, but they also have the ability to control heart rhythm by maintaining membrane stability. Now, another class of drugs, flecainide, which I'm not going to talk about much because I don't come across it very often in my practice. It has real problems for people with heart failure or other heart problems. This would be very tightly controlled in its prescription. And to be honest, I very rarely see clients who are on flecainide, but I've just mentioned it here as an anti-arrhythmic. Now, I'm just going to go back over those heart rate controlling medications that were on the previous slide very quickly. The beta blockers, tenolol, metoprolol, sotalol. Notice they all end in LOL, easy to remember. Calcium channel blockers come up again. AV nodal blocker comes up again. And now I want to move on to another intervention to try and get someone back into rhythm, sinus rhythm, normal rhythm, is cardioversion, which is elective defibrillation given under anaesthetic. And this is, the hope with this is that this will shock the heart or the atria, the upper chambers, back into rhythm. The success rate is reasonable on first and second application of this, but the long-term success with this is probably a little less. So we now move on to one of the really common modern interventions used for atrial fibrillation. And the first one of these is, these are grouped together as ablation therapy. An ablation basically is either applying cold or heat to create scar tissue. And in this first instance, I'm going to talk about pulmonary vein isolation. Now here we can see two pulmonary vein insertions into the upper left chamber, the left atrium, coming back from the lungs. And there are another two here where I'm pointing. So altogether there are four pulmonary veins. And what is done in the pulmonary vein ablation procedure is, first of all, they use diagnostic catheters to map the arrhythmias, and then what is done is they then use some ablation catheters to apply cold or heat to deliberately encircle the pulmonary veins with scar tissue, which will then prevent the arrhythmia from escaping into the rest of the upper chambers, the atrial chambers. And it essentially isolates the arrhythmia into these four small regions. And then the sinoatrial node, which is not shown here, can then dominate the rhythm of the atria and therefore the ventricles, and the person is then effectively cured in a sense in terms of their arrhythmia, although whatever underlying cause was responsible for the atrial fibrillation in the first place is not treated by this ablation technique. So, for instance, if the atria is still enlarged, then they remain enlarged after the pulmonary vein isolation, but they hopefully will be back into sinus rhythm. And this has a fairly good success rate. Sometimes the PVIs have to be repeated, but overall it's about a 70 to 80% success rate to maintain long-term rhythm in people susceptible of atrial fibrillation. So the next technique I want to highlight is atrioventricular nodal ablation. And I just mentioned atrial enlargement. And some of the patients who have very enlarged atria are not, they don't have a great success rate with the pulmonary vein isolation. And so another technique can be used. And in this situation, the ablation is applied to an otherwise healthy atrioventricular node in this region of the heart here, which normally drives the rhythm of the ventricles. So what we do, what's happening in atrioventricular nodal ablation is that this is knocked out, and so effectively the atria and the ventricles are electrically isolated or separated, so that whatever rhythm remains in the atria, which in this case will be atrial fibrillation, is actually not it cannot then get into the bottom pumping chambers, the ventricles, because the atrioventricular node, which is the controlling, if you like, the electrical filter into the bottom chambers, is now knocked out, and there's effectively an electrical separation of the fibrillation going on here and what will now be a rhythm. However, in this situation, a permanent pacemaker must be fitted, and I've illustrated that in one of my case studies in this series. So if this AV nodal ablation is applied, normally what happens is a pacemaker must be fitted either at that time or before that procedure is conducted in the same session, so that the ventricles are then paced in rhythm. Otherwise, this would be obviously dangerous because the ventricles would have to generate their own rhythm, which could be quite unsafe. So just to summarize, atrioventricular ablation electrically separates the upper chambers which continue in atrial fibrillation. So we're not ablating the pulmonary veins or any other part of the atria. They're ablating this otherwise healthy tissue, electrically separating atria and ventricles, and the ventricles must then need to be paced. And this is shown down here quite nicely. This is one of my clients who had this atrioventricular nodal ablation, and I've given you this in another case study so you can watch that other video. At pre-exercise, you can clearly see the atrial fibrillation in the baseline of V1, which sits over the right atrium, and so can pick up the atrial fibrillation. That is still existing, but in both of these leads, V5 sitting over the left ventricle, you can clearly see that the heart is now in rhythm. Even though atrial fibrillation continues, the heart is now in rhythm, and that's a really good outcome. And you can also control the rates really well as well. So in peak exercise, again, you can see the fibrillation occurring or persisting in V1, and also in, you can see a little bit of it in V5, but the heart at peak exercise remains in rhythm with good rate control. So we've got a really good outcome there. So that's what I wanted to do to summarise for you some of the main concepts that I was talking about for atrial fibrillation for exercise professionals, because people wanted a sort of a summary video, and that's what I've done here. And if you want to contact me about this or anything else, info@myfitness.com.au. So have a great day, and I'll look forward to sharing more cardiac physiology, especially for exercise professionals, in other videos. Bye for now.